We're on.
All right, welcome, welcome. Hello, everyone out there in digital Facebook land. Welcome to yet another CalCare Office Hours, which is a joint production of Healthcare for All Los Angeles and PNHP. You've got the healthcare advocates and the doctors coming here to talk to you once again about CalCare, AB 1400. So we're here to answer all of your questions that you may have about this lovely bill, and also talk about how it relates to different aspects of our world currently and how it makes things better. We talk about a little bit of this, a little bit of that. We go down a few rabbit holes, and either way it goes, 2 hours disappears really, really fast. But nonetheless, we are here to talk to you. So feel free, if you have questions, please drop them in our Facebook chat where they will be picked up, or you could pop on into the Zoom room. No hesitation, come on in. We're all friends here. So with that being said, we're out there in digital, give everyone a few minutes to get on in here. Welcome to everyone in the Zoom room. We have a special treat. If you were here and joined Healthcare for All Los Angeles monthly meeting last Monday, you heard from Ms. Barbara Commins about Medicare and Medigap, and she's here also to talk about how this relates with AB 1400. But first, I'm going to do what I do best, which is go over what AB 1400 is. If you guys have not heard about AB 1400 or uncertain about what it is, I'm going to go over what we call the CalCare 7 basic principles, which allows us for me to go over this very extremely comprehensive bill in just under a few minutes if I could get Zoom to share my screen. So you give me 2 seconds here. It never fails that I have some issues sharing my screen. Why is this it's not showing?
You're not doing share screen?
Oh, here we are. I got it. All righty. It just never, it's like I have to click share, then unclick share, then click share, and then finally the screen will pop up. Anyway, all right, so CalCare is California's guaranteed health care for all. This bill was brought forth by the California Nurses Association. So we want to give a big shout out to the nurses who have been our advocates since before the pandemic, but now it's been fully on display during the pandemic, they're burnt out, they're tired, but they're still fighting for you. Myself included. So California Guaranteed Healthcare for All Act is the solution to our broken, very broken healthcare system. It will guarantee healthcare as a human right in the state of California by providing comprehensive, high quality healthcare, emphasis on that high quality healthcare, just like Medicare for All will do nationally. It provides universal coverage, which means everybody in, nobody out. If you have a body, you are part of every. If your body is in California and it's a resident, you're a part of every. We are not covering aliens from the Andromeda galaxy yet, or sentient kind of celestial beings. But if you become a resident of California, you may get covered. I am welcoming of all people, even those who may not be from this planet. I think it might be cool to get to know you. Okay, I'm sorry. Anyway. But I do say everybody, regardless of your race, sex, gender, country of origin, disability status, immigration status, marital status, age, and income, you get the care you need regardless of the ability to pay. Hence the reason why I make the joke about friends from the Andromeda galaxy, because I just covered everybody. This is a single public program, which means it's publicly funded through progressive taxation. I just said taxation, hold it, pause. My conservative friends just had a heart attack. Pause, progressive taxation, okay? Emphasis on the progressive. That means kind of the higher the income you get, the more we might pinch off a little bit, because that kind of means that a little bit more that we can pinch off is there. You're not going to miss paying your mortgage payments. Life will be okay. And actually, when you really add up how much you're being penny pinched right now for your healthcare costs, you may not even notice a difference, truthfully. But we have to be honest, and being honest says, yeah, there will be a little progressive taxation to cover all the necessary care in California. This will help eliminate billions in bloat and waste. And what is that? Billions of bloat and waste mean these unnecessary admin costs. there is a growing kind of exponential growth in administrative costs. People just sitting there trying to bill, trying to code, trying to do things that really don't have a whole lot to do with you getting the care that you need, but it means that the insurance companies make that they pay out properly, and that those doctors and those hospitals and those places where you actually do get the care get paid properly. So they have to invest more on that admin side to make sure that they get their claims paid out timely. Sounds like we could kind of eliminate some of that, right? And so we're also saving that people thousands on their healthcare costs. So if we're not having to fight so much to just get those stupid claims paid out because we forgot to put the C.7.026 whatever, and we have a single public program where even if we did forget it, it's a single stream of information coming back down, going back up. It's not going boom, 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 boom. And just for you to say, well, you forgot to hit that 0.0. So we're going to deny this $50,000 claim. Then you've got to go back, boop, 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 wait on hold 45 minutes, 50 minutes, 60 minutes, an hour, all through your lunch break. I'm not bitter. This is what I do. You know, all through that just to get that claim paid back, just for them to tell you, you forgot the 0.0. What? That is a waste of money. Anyway, we're talking full comprehensive benefits, medical, dental, hearing, vision, mental health, which is so important right now, prescription drugs, long-term care, and more. Imagine if Trump had the therapist he needed as a child, he may not have been the asshole he was. So just putting that out there. If I had the therapist I need, I might not be this kind of like crazy person. Anyway, mental health, like I said, extremely important. Prescription drugs, extremely, extremely important. You guys are hearing about this. Pharma coming after Medicare, you know, as we start to talk about, you know, Medicare renegotiations. And it is extremely important because even right now under Medicare, the current system, our elderly are struggling to afford those prescription drug costs. And that is just a shame that we cannot take care of our seniors after they've contributed X amount of years to this country and their tax dollars, and we still can't cover them fully for what they need. And so long-term care is another important thing, going back to our seniors who have contributed all throughout their lives. And now they're here at the end of their life where they should be enjoying it. And most of the time, them and their families are spending countless hours trying to figure out how to afford the care that they need. Ridiculous in the richest country in the planet. I would dare say the solar system, because we haven't found much life around here. So I could say the richest planet or the richest country in the richest state on the planet, in the solar system. Ridiculous. Anyway, all decisions about your care will be made between you, your doctors and nurses, not the insurance companies. Once again, I'm sorry I got to digress again and tell you what that means because I've done it. So when we say decisions will be between you and your doctor, if you go and let's say you need your knee replacement because you were a marathon runner, great for you, I can't run a mile, and you need a knee replacement and the surgeon, you know, doctor refers you to an orthopedic surgeon says, all right, great, we're going to get you ready for surgery, we're going to replace that knee, you'll be back running. Well, that orthopedic office then applies for authorization from your insurance. Yes, even if you have a PPO, they still apply for authorization because this is considered an elective procedure. And with that, your insurance company looks at this, and here's what I talked about, those codes. And let's say one code was missing, one thing was wrong, something, you know, maybe the doctor's handwriting or signature didn't look as clear as it was via fax, whatever, and it's denied. And they don't know why it's been denied. So that orthopedic surgeon's got to go through the denial process and maybe do a peer-to-peer with the medical director of the insurance company that has never seen you, is just looking at your notes, to determine whether or not this is actually an appropriate procedure. Meanwhile, you're waiting, your knee is in pain, it's getting swollen, you can't run anymore, you're grumpy, you're angry, you're kind of like not knowing where this is in the process. The orthopedic surgeon's office is just saying, we're waiting on authorization, we're waiting on authorization. And so weeks and weeks and weeks go by, that knee's getting more and more painful. Now you're a little debilitated, you're not at your full function. You may be getting a little weaker if you're older. So maybe now, once that authorization finally gets approved, they finally get that all corrected. Maybe it took a week. If you had a diligent person behind it, it could have taken 2 months. It could have taken 3 months. Now you are having that surgery. That surgery is now probably a little bit more invasive. You are going to need a little bit more recovery time. You may even need more rehab. all because of some small error, maybe miscommunication, maybe the facts wasn't clear and they denied your claim. So that is what the decisions between you and your doctor, that orthopedic surgeon should have sealed that deal. Instead, it was the decision of the insurance company that delayed your care. So that is what that means. You have your freedom, the next step anyway, freedom to choose your care provider. So no more in-network, out-of-network. You want to get rid of your doctor because you don't like him. You guys don't have a good relationship. You think that you got referred to, your friend is saying this doctor's so great, you want to check him out. You don't no longer have to call that office and say, do you take Anthem? Do you take Blue Shield? Are you on Kaiser's network? You don't have to do that anymore. Freedom to choose. You call them and like, hi, I have my CalCare card. I want to know if the such and such doctor is taking new patients. Yes, these doctors can still have a full schedule, so they may not be able to take new patients at the time. But nonetheless, if they are taking new patients and you have CalCare, guess what? You schedule an appointment, you're done. Period. That's it. And so now we're free at the point of service. We are talking about no copays, premiums, or deductibles. I will give you a prime example of this. On Friday, I am working. It is about 5:30 p.m. Mind you, I'm supposed to get off at 5. And one thing I noticed was that a patient's medication, she was going to discharge, patient's medication copay was a little high. It was over $100. Now, anything over $50, I usually am like, couldn't they afford it? But over $100, I'm definitely going to the room to ask you, can you afford it? So this is about $150 copay. So I had to go to the room and ask, patient, I just wanted to let you know, I saw the copay on this medication. It's actually kind of high, but it is a medication you must have. You must have it. And can you afford this copay? Is this copay okay? Thankfully, it was okay. Sure, they were like, okay, that's fine. But for many, this is not okay. So, copays, premiums, deductibles can really interfere. I may have had to keep that patient in the hospital another day because it was so late, spending thousands of dollars more if they couldn't have afforded that $150 copay. You see what I'm saying? Does that make sense? Does it make sense to literally have to hold a patient in the hospital because they can't afford a medication for me to give me time to try and see if I can find coupon codes or something like that to make that medication more, affordable, versus just saying that, okay, hey, your medications are in the pharmacy waiting for you to pick them up. Bye. Does that make sense? I could have wasted thousands keeping them in the hospital overnight. So I'm just putting that out there. No copays, premiums, or deductibles. Your CalCare card is all you need, and it's that simple. Just transition. Well, Gina, the insurance company employs thousands and thousands here in California. You're absolutely right. So within this bill, because it was help written by a union, they have also included a just transition, which is funding and programs to protect and support any displaced workers in the insurance industry. I am pissed off at that leadership. I am not pissed off at that individual worker working for that company to make their ends meet. So I'm just putting that out there. This is not an attack on the individual worker of the insurance industry. This is an attack on the greed and profit-driven leadership that allowed the system to exist, knowing it was wrong. Point blank, period. And lastly, patient care based on patient need. No more financial incentives to avoid providing necessary care. That means basically it's illegal to deny, really. We can't just deny on a pre-existing condition, but you can if, for example, you decided not to contract with a place that handled like high-level cancer patients because you didn't want to take those high-level cancer patients in your group. It's not avoiding per se, but it is technically, going around the loop-de-loop. So there should be no more financial incentives. The rate should be cut across the board. Like you should have the same rate here as the same rate there, right? So that there's no more incentive to try to send someone to a lesser cost hospital just because the cost is less. The care, but because the cost is less, you're sending that patient around when they need to go to some other place, maybe to get the care that they need. So that is a financial incentive to avoid providing necessary care. And in a very, very, very long-winded way, I am so sorry about that. That is your CalCare, AB1400, guaranteed healthcare for all here in California. Thank you. And I see a hand up from Dr. Bill.
Well, thank you. That was excellent as always, Ina. And sorry, I jumped on a couple of minutes late, but I did catch most of the 7 principles, which I hate to miss. I try to make it every Sunday or at least that. But I did want to back you up maybe on a couple of things if I could. So I don't know if that's
Welcome
to do right now, or do you want to go to something else first?
I wanted to take a quick moment at the beginning of this, the top of the hour, to just talk about reproductive freedom. So because we just had the Women's March for reproductive freedom across the country, thousands of people, and I want to say over 100 cities across this country were out in the streets again, basically saying, you know, excuse me for being crass, but my body, my vajayjay, should not be your regulatory principle, should not be in your mouth, okay? It should not, you should not be regulating my body. And here we are in 2021, right? 2021, acting like it's 1861. And for some reason I have to fight to tell people who have never had to experience period cramps. I'm going to be crass. I'm just putting it out there. I had, you know, hormone headaches last week dealing with this, and I'm still at work for 12, 13 hours. And so these people who have never had to experience that are sitting in Congress and sitting in their houses and their legislators who have never had to experience a hormone migraine or cramps, telling me that I can't get shit done in my, what? And here we are in 2021. But the reason why I bring that up is because single payer CalCare is so important to this. In California, we are a pretty liberally reproductive state, right? We've always been, you know, and so CalCare does guarantee comprehensive reproductive rights. So it's basically building on what we have now and making it better. So we even know there's the Hyde Amendment that affects the federal, where you can't, like federal funds cannot pay for like abortion services and things like that, which is complete BS. This is reproductive health, okay? Like I deal with gynecology, oncology as part of one of my departments. And I can tell you that the things that I have seen have had to happen, not due to someone being irresponsible, due to just shit happens, okay? Things happen during pregnancy, things happen to us, and especially with the environmental input, you know, tons of crap is happening to our bodies, and we need to be able to get the care that we need. So when you bring in a single payer system, it takes us to a new level. It allows us to seek care when we need it, not to hesitate, not to sit there and wonder, well, if I can't afford it here, maybe I can go to Planned Parenthood, which we're very grateful to have here in California, and you know, and around the country. And even though on a daily basis it's being attacked, it's more than just an abortion clinic. Women go to those clinics all the time, and men when they need their STD checks, and when, you know, men when there are you know, other issues going on. I've seen men in Planned Parenthood too, sometimes an equal amount of men to women. So don't think that Planned Parenthood is just there for a woman's clinic. It's not. But nonetheless, I digress. I'm just saying that CalCare is really important to reproductive freedom. It will allow us to seek the care that we need when we need it. And also, once CalCare is passed, I can't emphasize this enough, how the importance of building on that, allowing us to now start breaking these stigmas of talking about our reproductive health. That's another thing. As women, as teenage, you know, as young women, especially teenagers, a lot of things are stigmatized. We can't talk about a lot of things that have to go on with our reproductive health because of the stigma around it. We're embarrassed. And with a single payer system where we can really focus on that, where we can get the care that we need and hopefully not have to have so much kind of conversation around it, make it normal to seek, you know, to have our reproductive health taken care of. For men too, like, you know, for men too, there are a lot of questions around reproductive health for men that go unanswered because it's so stigmatized. So I just wanted to take this time to talk about why a single payer system providing access to care is so important in this aspect, because it's also, lastly, very cost effective. You know, when women withhold or, you know, do not seek their care that they need, especially cervical cancers are something that should be almost obsolete. We should not see the prevalence of cervical cancer, breast cancer that we still do, because a lot of it is just delay in care, delay in seeking care or having that routine, you know, regular preventative care done. And a lot of that goes back to cost and stigma. Those are the two things plaguing women all over this country that are preventing us from seeing, you know, care. And I hate to, on my services, see women in their 20s and 30s having full hysterectomies because of cervical cancer. That's what's happening every single day. And that could be prevented. So past CalCare. Okay, I'm done. I'm going. Okay, Jeffrey.
Oh, I'm sorry, because I was waiting.
Oh yeah, go ahead. I'm sorry, Dr. Bill. I put your hand down. Go ahead.
So, and Jeffrey, sorry if I'm bumping you for a minute, but I did want to add to what Gina just said, which is that that abortion care is healthcare. Okay, so and it's a public health issue. It's a women's rights issue. That makes it a human rights issue because women have the right to determine their own personal destiny. That includes your medical care, and that's.
Are you sure the legislators don't think we're from the Andromeda galaxy? Are you saying that we're actually human?
There's probably at least as many men or more men probably from Andromeda than women. But anyhow, no, they're from Mars, right? And women are from the anyhow. But it's a public health issue. I would just bring up a little historical point that the history is that women die when it's made illegal. They died before Roe v. Wade because of a condition called septic abortion, which was a back alley abortion, meaning abortions done when it was illegal and unsafe and done in unseptic conditions. So we don't want people to die. We are the real pro-life people because we believe in a woman's life and protecting a woman's life and her right to choose. And so that's what the whole misnomer of the pro-life movement is. They're really anti-life because they're anti-women's life. So that's why it's so important. I think it's a human rights issue and it's a public health issue as much as seat belts or traffic signals or safety caps on medication bottles, you know, are public health issue or helmet laws are, you know, tobacco in public places. Those are public health issues. So is abortion. It can be done safe, legal. It needs to stay that way. Thank goodness it's done in California that way, and it will remain so under AB 1400. What I wanted to back you up on was a couple of things from the 7 principles of CalCare, if I could, and hopefully Jeffrey will indulge me for just a couple more minutes. So first of all, the bureaucracy, which is why I have the spaghetti diagram. And you're right, it's not just administrative waste, but it's fraud and abuse. This is where they hide those backroom deals that end up with surprise medical billing that people get when they go to the hospital. What Gina in her day job has to do to so artfully unscramble the spaghetti and make sure that people can get from point A to point B in this nonsensical system of payment that we have in this country, which could look nice, standardized, open, you know, fully disclosed, like they have in Canada and other countries, and especially cheaper, save so much money in the process, and not allow for these backroom deals, and especially extortion business model practices where they can charge us for these things based on what our money or what our lives are worth to us, not what it costs them to provide these unscrupulous services. So just to add to what you were saying, free at the point of service means a whole lot of things to people like me, and I know others of us here in the room who have been, you know, on the provider side of things, trying to get people the care that they need. When they refuse care because of the personal cost, out-of-pocket cost, due to a copay or whatever, like you were pointing out, Gina, in your professional experience, people would refuse care or get angry at the provider because they were told there's a copay involved, or just walk out without their CAT scan or their ultrasound that could save their life if we just knew what was going on with them. Instead, they would leave against medical advice, and you're supposed to just throw up your hands and get their signature on a piece of paper, like that was enough somehow. And yet we were supposed to go home and live with that we couldn't convince them to put up that money for the deductible or copay. That's just wrong. It's unacceptable and not done in civilized societies like it is here. And finally, I just want to share about Big Pharma because you brought them up. And I don't think I've ever shared this before. Can I screen share one slide I'd like to show from a PNHP talk that I've given over the years? I'd like to do that, Paul, if I could screen share. Thank you. That's this one. These guys, Big Pharma, are corporate robber barons to the worst. They are stealing and murdering Americans. And this slide's a little old. You can see it as of 2015 was when the data was stopped to be collected. These numbers are probably worse. But what this shows is the profits that drug companies make compared to those of the Fortune 500 companies of the world. These are the 500 most profitable companies in the world. Look how much more money drug companies, U.S. pharmaceutical companies make compared to those of most profitable companies in the world, 4 or 5 times as much profits. What do they need that? What are they doing with all of that money? And you know, as I've shared with this group before, something like the EpiPen or insulin, or you know, or some of these chemotherapy drugs, they are not that expensive to make, to produce and distribute. An EpiPen should probably cost about $1.25 in the product. Let's give them another $5 or $10 for overhead and profit. It should cost $10 out the door at Rite Aid for an EpiPen. Instead, they're charging $350 per unit. That's just not right. We've got our wallets open to these crooks. And thankfully, you know, AB 1400 has that built into it, where California, the 5th largest economy in the world, can bargain for negotiated drug prices, just like we're asking Congress to give the ability for Medicare to do, and the VA already does. We can do that in California because we're, you know, 40 million people with that kind of consumer voice. We could bargain down those drug prices, save a lot of money, and save a lot of lives in the process. Thanks.
Thank you for that very, you know, explanation. It's coming out more and more. We are being robbed blind, and we're okay with it because for generations we've been robbed blind. And for as long as I've been alive, I don't know any other thing other than being robbed blind. But anyway, I don't want to hold, Jeffrey, I know you've had your hand up. Thank you for waiting.
Well, what I want to, shall we say, throw into your discussion tank is one, Texas is the one that dealing with female rights, but I think your number one, everybody in includes everybody. So women, all of us are included in that. That's why we're pushing this. But at the same time, the Affordable Care Act only got 26 states here involved with it. And that's where from that came out the surprise medical billing. Because before that, it was treated as a contribution, and still in some operations, what Medicare doesn't pay is treated as a contribution operation. But upcoding is something that I have to realize has been going on for, I would say, more than 40 years. I was involved with the medical industry doing the medical billing in the 80s and 90s, and note that, you know, literally the insurance premiums were going up at minimum of 15% more than inflation every year through that period of time. So until we get a handle, and one of the ways I think in California is maybe we ask for Medi-Cal expenses to be sent at the end of the year, the total expense to each individual client, each individual patient, so they realize how much. And if there's a question on it, that there's a means of which arbitrationally brought out about, why did I charge this or that? I bring that up because, as you mentioned about the insulin and you mentioned about the EpiPen, yes, there's another pin that will do that comparably, but we need to get the public information out on that. Vaccines. I think it's ridiculous when you're charging the same copay for shingles vaccination as you're charging for the diphtheria tetanus shot. That's been around for 40, 50 years. Why is the copay exactly the same for both of those shots? It's again, what's the insurance company set and said, oh, we're going to charge, we can get away with charging premiums this way. We're continuing to do it. We need to have a mechanism in this process by which we ask questions. I know when Ashkara first came to the legislator, Kara said to them, he's a brand new guy, let's work with him. And I think we've built what's up there. You say, what is upcoding? It's taking a basically Medicare code and where is the way of expensing it out? So in other words, if there's a way of saying, if you've got a mental health issue and you've had 2 visits, this is the type of charges that you can go through a range of, not an initial consultation for a medical health checkup. That's what upcoding does. So in other words, as was pointed out with the September 23, the I think that was a very good point to bring up in the factor of thinking that it's state organizations or the providing direct services. I did this simply as part of an insurance billing outfit operation. And this is what, because I had an original Medicare encoder, knew what all the codes would do and where they would derive out. So how would you increase that to charge Medicare for, what this expense is? So it would make a patient billing far larger. And that was what was pointed out. So we need to find a means of reminder of how we get Congress and how we get our legislators to get a way of controlling the costs by first showing what is the medical costs that is ongoing in California and in the country. That's my box office for the moment, and my listening and reminder, as I told to the doctor, hey, this coming Tuesday, our Dr. Wood is going to be having a information hearing on nursing homes. Last year he did it on medical costs, so it's still a report out there. He's doing it on nursing homes now. And I hope that you guys talk a little bit about what's going on next Monday because that 9 o'clock in the morning to 3 for the discussion about what providers are going through for the Healthy Commission. We need to throw more input and see exactly what they mean by provider. Raise the question now, what do they mean by providing of services? Anyway, I will end that of the 3 subject matters that I'm attention on for this week.
Right. Thank you, Jeffrey. I appreciate that feedback. And it's interesting you brought up Encoder because let me rephrase. I'm not familiar with Encoder Pro. Somebody gave me access to Encoder Pro and I had to figure it out. So that is how things are getting billed by people who, like me, who have to figure it out. Or authorize, because I was like, I don't know what Encoder Pro, what is this? And I'm like, wait, there's a software for this? And I'm like, you didn't even know there was a software. It was like one department had access to the software, the Encoder Pro software, which gave us all these codes. And I'm over here Googling it. I'm like, what is the code for this? And what is the CPT code for that? And they're like, why don't you just use Encoder Pro? And I'm like, my department in the case management, we didn't even have access to it. I had to go ask someone for it. Anyway, I'm sorry, I digress. You mentioned Encoder and I had a little PTSD moment. Maureen, I see your hand up. I just really quick, I want to go to Randy's question from Facebook. So it's been sitting there for a minute, for like 20 minutes.
I did want to respond to Jeffrey though.
Oh, okay.
And go to another topic. Just a quick response. Jeffrey, that's why we're working for AB 1400, because AB 1400 would take care of this. It removes insurance. It removes the profit motive. It removes healthcare as a business plan. And, you know, so these issues that you brought up about, you know, the coding and how much things cost, you know, price and cost are two different things. A good go-to source is truecostofhealthcare.org, where Dr. David Belk in Alameda discusses the difference between prices and costs. And what AB 1400 does, it sets up a panel that, just like Medicare has, that decides the what the payments will be. So we in this country are paying prices that do not reflect the actual cost of the services that we are receiving, the services or the pharmaceuticals or the, you know, the medical devices. So that's why we're working for AB 1400. We don't want to work piecemeal and deal with the coding and, you know, deal with trying to bring caps down. And no, we want to deal with an entire reform. Once you remove the insurance industry, once we remove the for-profit, and once everybody is in the same system, we are going to control those prices, and people are not going to get billed. We're not going to have people billed. So that's not going to be an issue. We don't need to show people how much something costs because they won't be billed. So these are all included in AB 1400. I highly recommend you have a look at it because it will, you will rest easier. And in a bit, we'll hear from Barbara Commins after a few questions more, exactly about how, you know, Medicare deals with the situation and how AB 1400 would help improve Medicare and solve some of the problems we have, especially with Medicare Advantage, which is very important.
So just to say also, I mean, from what I was taking Jeffrey's question about upcoding, I think that we are still going to be vulnerable and under AB 1400 unless you have a diligent board who assigns people to review. I do think that they do need to review the cost, the in and out, which is written in AB 1400 of an annual review of the expenditures and the spend of what's going on here in California. But upcoding is something that's taught and it won't be easy to remove. And, you know, and especially when it comes to establishing the global budgets. So like I said, everything has a vulnerability, and all it takes is an evil mastermind. That's why the evil master, you just need to grab the evil masterminds and put them on the side of good, bring them to the good side of the force before the dark side of the force grabs them. I'm for hire. No, I'm kidding. I'm for hire. We want our, you know, if you can figure out a flaw on how this system, how AB 1400, a vulnerability, I encourage you to reach out to Ash Kalra, reach out to Alex Lee, reach out to these authors and co-authors of this bill and talk to them about it and say that you support this and you see that there could be a little snafu here, because all those brains coming together brilliantly will make this system as flawless as possible. But I do see that, yeah, there's still going to be some vulnerabilities, but it is a hell of a lot better than what's going on now. Let me tell you, by like light years, like my background, it's in warp speed right now. Passing AB 1400 launches our healthcare system into warp speed and getting us back to where it should be if had it not taken these for-profit derailments. So we're getting ready to hit warp speed on improving our healthcare system by passing AB 1400. Are there vulnerabilities? Yeah, there are. But at the same time, vulnerability is everything. But this, like I said, to help 40+ million Californians all at once, that's nothing short of remarkable. Unheard of here in the United States. It's pretty average everywhere else. It's like the pumpkin spice latte. Like we think we're fancy for getting a pumpkin spice latte because it's like latte, but it's really the biggest basic thing that you can get right now. So us passing AB 1400, it's really like going to Starbucks and getting a pumpkin spice latte. We feel like we're fancy. We feel like we're doing something, but really we're pretty basic compared to the rest of the world. Like Norway and Finland and Sweden are all looking at us like they got a pumpkin spice latte. That's cute. Anyway, I digress. I'm sorry, Randy, I'm going to answer your question about how would single payer help regional center clients. In the section about benefits. I pulled it up and then I went into financials looking for what, you know, Jeffrey was talking about. So in the benefits section, I think it's number 14, healthcare items and services previously covered by a regional centers for person with developmental disabilities pursuant to Chapter 5 of Division 4.5 of the Welfare and Institutions Code is covered under AB 1400. So basically, this bill is not taking anything away. What's already there is there. We're just building upon it or filling the gap, you know? So the care that's provided by the regional centers is fantastic that it's there. It is way underserved, in my opinion. We really need more support in those regional centers. But the care that is currently being had there, if AB 1400 passes, will continue, hopefully improve with time. Okay, sorry about that. And then I just wanted to go, so yeah, I mean, actually, I wanted to go to Barbara and just kind of bring you into this conversation. You know, we've been talking about AB 1400. I know you're aware of it, but you know, you're under the Medicare. You know, we're talking about pulling in part of Medicare. We're pulling in all the Fed and all the state and putting it all into one umbrella. But you know, a lot of people talk Medicare for all, and I know you just talked about this. So can you go ahead and expand upon that and how this is better?
Yes, I will try. Okay. Good to be back. Good to be back with good people. Yeah, so we talked about original Medicare or traditional, and this was the one that passed back in 1965, and it has survived better than ever, 56 years old, okay? So what we want to do is take it and improve it and then expand it and give it to everybody. And the two important parts of this process are one people, one plan. We're all going to be in it, and it's not going to be money spent, you get this, you get that type thing. We won't need Medi-Cal, okay? Medi-Cal or Medicaid is basically health care for the poor, and it really doesn't belong in the wealthiest country of the world. We need to be one people, one plan. And the second part of this is, right now, we have come out of, well, we're coming out of a pandemic, and there's a tremendous amount of cooperative spirit among people. And we know what happens when we face something together and we help each other out, protecting each other from getting COVID, and we've done it. Okay, a lot of people haven't survived, unfortunately. We've learned more and more how important face masks are and social distancing, and now the vaccine. But we have had an experience in the public health, like it or not. I mean, it's sort of been laid on us to do this. So I think now we're a little bit more open. Also, the fact that people have lost their health care through their employment. And this is another big tenet of Medicare for All. Disconnected from the job. Just think about that. Think about the freedom people will have with their lives and how they use their labor and how many hours they choose to work and whether they change jobs and on and on and on. So CalCare AB 1400 gives us a chance to do it on a smaller scale. Some people say it'll never happen nationally because there's so much diversity in terms of populations. Rural, urban, etc. I think it's important to push on both fronts. Okay, but here in California, being one of the biggest states and also one of the biggest economies in the world, I think it's the 6th largest economy, we have a chance to really lead on this. If we can do this in California, it's going to it'll sweep the country just like it did in Canada. I would say California and New York, if they could each pass this, I mean, it would just sweep the country if people can see how it works. Not connected from your job. No money up when you go to see the doctor. No worries about a deductible or a copay or a bill coming, things like that. It would just sweep the country. So we need two models. We need, well, at least one model. Let's work on California. And we can do it. This is the third bill that I've worked under since I've come aboard about 20 years ago. The third bill, 810, 562, and now AB 1400. And this one's in the Assembly instead of the Senate. And that's important too. And maybe Maureen or someone else can talk specifically about that. We've got a good group of co-authors, and I think we can do it. And AB 1400 is modeled under traditional or original Medicare. Okay, but again, we're going to add things to it: vision, dental, long-term care, hearing aids. Okay, and we're going to expand it. And healthcare will just be there, not connected to your job, not depending on your income, etc. So that's my vision. And I want to encourage people that we have been waiting too long, and we're not going to take incremental reforms like lowering the age 5 years. It'll take forever to get to that. We're going to do the whole thing right now. And this next 2 years are probably really important because we have the coming elections in the House, and we have to still get through the pandemic. So that the people power is on, and the political power is on. And there's more of us out there than there were when I started 20 years ago, let me tell you. So we can do it. Thank you.
No problem. Thank you. Thank you, Maureen, and everyone else who has been fighting this fight. Like you said, incrementalism, let's see. Medicare passed in what, 1965?
Mhm.
So I guess if they would have started 5 years at 1970, would we have been fully covered by now? Maybe, right? Yeah, we would have been fully covered. So they should have started the 5-year plan but in 1970 instead of 2021. Not any issues though. Like, I mean, thank you to all the progressive leaders at the national level fighting for this right now. They're fighting for any and everything they can get. I know how hard it is to get this passed. And I know that throwing a bill out there that says everybody right now, that will be spit on by a lot of the moderate and Republican up in the national level. So 5 years, I'll take it. I'll run with it. I'll run with whatever you give me. But like I said, like Barbara said, incrementalism should have started in the 70s, well before I was born. That's about 17 years before I was born. So that's when that should have started. If you really wanted to be pressing on this incrementalism, you could have started it when, the Democrats' Lord and Savior, Bill Clinton, had balanced the budget. That would have been a really good time to bring forth single payer. When the Lord, their Lord and Savior, Bill Clinton, had balanced that budget, and everyone brags about that time of life. I think I was in elementary school then. Pretty sure I was in elementary. But I heard that was great. My mom was happy about it. I do remember that conversation with my parents. But that would have been a good time to start moving forward the healthcare system a little bit and wait. And now here we are, trillions of dollars in debt to, I don't know who. I mean, who do we pay? Like, we're trillions of dollars in debt, they keep saying. But I mean, when you're the world superpower, who do you really owe? Decepticons? Do we owe? Like, who do we owe? Who is our creditor here? I mean, is it our FICO score going to go down? Like, what's going to happen? Okay, I digress on that. I'm sorry, guys. I just want to answer a couple of quick questions from James from Facebook. And he was saying, what happens if hospitals who claim Medicare will bankrupt them carry through with their threat? I'm not 100% sure on which threat, but I know hospitals, a lot of the hospitals, Medicare is now their bread and butter. So I don't think that Medicare is going to bankrupt them as much as those PPO plans will, negotiating those rates under the Medicare rate. That is the goal. Like, Medicare rate can sometimes be the creme de la creme, depending on the hospital system you're working with. The lesser hospital systems, those plans will come and chomp down. They'll be like, we'll pay you 80% Medicare. We'll pay you 70% Medicare, which means Medicare rate. So if you have a Medicare A and B, like fee for service, like regular Medicare, oh man, we love you. Do you know how easy it is for me to staff home health, get an ambulance, a nursing home when I have a straight Medicare A and B person versus a Medicare Advantage or a health plan? I can tell you the time difference. I'll send out a referral for a person that needs to go to a nursing home for whatever reason. or, needs home health for whatever reason, those home health companies and nursing homes will reply back to me. I kid you not, no more than 20 minutes on a straight Medicare. I can accept, I'll see my whole screen go available, green, 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 green. But if I have a patient that's under Medicare Advantage or a health plan, I'll see yellows and oranges, under review, insurance mismatch, blah, blah, blah. And it is so Medicare, honestly, now has become kind of the standard, like the gold for providers, because they love Medicare fee for service. So that's A and B, original Medicare. Part C, that managed Medicare, that's another one. Well, those are the ones negotiating under those Medicare rates. So when it comes to that, I'm not sure about the Medicare bankrupting them as much as those for-profit health plans will. But, James, if you want to elaborate a little bit more, maybe, I don't know if I answered that directly or not. And then how often will AB 1400 negotiate prices? I was looking at that in the bill, and I want to say it's annually, but there's a couple of different places in the bill that address negotiating prices. I did see annual on one thing, but then when it talks about the negotiation of prices to be paid for pharmaceuticals, medical supplies, and medical technology and medically necessary assistive equipment, that it kind of is ongoing. And it said that they shall be on behalf of the entire CalCare program. But I know in other countries, it's either annual or like biannual. So some countries do it every 2 years because, you really, when you're dealing with big data sets like that, you really do need a pretty good, decent set of data, chunk of data to really analyze trends. So I would go back in and look and see if it's annual or biannual. But I know in countries like Japan, it's biannual. I think it's every 2 years that they go in and negotiate prices. But I will have to dig more into the bill because I see it in different spots, but it doesn't definitive. I don't see a definitive, and I could have looked over it too. I have on glasses, but it's more for look than it is for anything else. Okay, Maureen.
Yes, I'm so glad, Gina, that you brought up Medicare Advantage versus traditional Medicare. And this is something Barbara has dealt with.
That was a good segue, kind of like
as well.
Turning into that.
And that's because it's very, very important to understand there are basically two Medicare systems of payment. One allows the for-profit insurance in, which costs us about 17% more than the traditional Medicare, and that's Medicare Advantage. It's also doesn't provide the best care. The Department of Health and Human Services does audits, and their last audit, which was in 2018, one is due this year, it's not out yet, said that there were Medicare Advantage, though it has increased dramatically to 21 million recipients, the denial of care and the number of people that have to appeal denying their care is really troubling. What they say is the high numbers of overturned denials as well by themselves is also troubling, because only about 1% of people actually file an appeal for denied care. But of that 1%, so there's only 1%. But those that do file an appeal, the insurance company itself actually overturns its own denial in 75% of the cases at the very first stage. And there are 4 stages of appeal through Medicare Advantage in order to have your appeal honored, right? So even at stage 1, the entity that denied care, if you appeal, it 75% of the time will in fact give you the care that they originally have denied. And as you said early on, Gina, that denial, it's like justice, right? Care delayed is care denied, because people become sicker and they become more debilitated and they suffer more and the costs are higher.
You want to speak about denial?
Yeah, and it's very important, especially we have to look at Medicare Advantage is a huge profit maker for insurance companies. And we know this especially because we're looking at right now, right now, the for-profit payers are lining up to increase their Medicare Advantage population. And we have just this year, United Healthcare is expanding its Medicare Advantage plans to 276 counties to continue its dominant market control. Clover Health is doubling its Medicare Advantage reach by entering 101 new counties in the state of Tennessee. Nebraska distributor, the Senior Market Sales, is actually working with 350 Walgreens stores to sell Medicare through agents at Walgreens. Cigna has launched a new Medicare Advantage program called Belong Health. Humana has broadened its Medicare Advantage program to reach an additional 72 new plans. The parent of Blue Cross and Shield is enrolling businesses in more counties and into 90 additional counties. So we see that these, on Cigna is also chartering its third year in a row of Medicare Advantage plan expansions, entering 3 new states and 108 new counties. So we see that Medicare Advantage is a huge hole in the system that is basically sucking out our Medicare funds for profit. Because each one of these companies, right, they're doing this because they're making enormous profits. And James brought up the issue of solvency, and that is a concern. Right now, that is a concern. But one of the major drivers in this concern of the financial stability of Medicare is the Medicare Advantage program. And so AB 1400 gets rid of any kind of a tiered system. It basically is a tiered system, Medicare Advantage versus traditional Medicare. And right. So that's one of the advantages of AB 1400 is that we would save a lot of money by getting rid of this Advantage program and folding everyone into one system, because we know, if I say it over and over, if the governor, the legislators, you, me, the unhoused, the seniors, pediatric patients, the undocumented, if we were all in the same program, one plan, nobody can like buy their way into something different. 3 things would happen. We would have everything we need. It would be high quality and it would be well funded. Believe me, if Governor Newsom was in the same plan as everybody else, and if every legislator was, we would see quality care and there would never be an issue of funding. The funding would always be there. And this is the danger of people talking public option and saying, well, you know, let people who want to buy something else, buy something else. The danger with that is the people that are buying something else are the people who are making the rules for the rest of us. This is a problem. We want them to be making rules which cover themselves as well. Otherwise, we're always at risk for getting poor care, being overcharged. So we can't allow that to happen. So that's the beauty of AB 1400.
Yeah.
Barbara,
So
did you have anything to say about the
I just wanted to add really quick
sure.
why this is critical we do this now. Like you said, all of these plans are jumping in. They are adding benefits that original Medicare doesn't cover. So Cigna may cover a little vision. This plan may have a little dental plan. This vision may have something. My mom's on Medicare Advantage because she has glaucoma and needs her eye drops. And she had to take a plan that covered vision. And I couldn't stop her because you know what? Those eye drops are expensive. And so right now we need to pass this before it's too late, before the people are like, but this plan offers more than Medicare. And it's because the plans are penny pinching off of Medicare. So the original, what should have always been and should always be, is being defunded by the health plan. So the health plans are pinching away and getting corporate tax cuts on top of it. And they are not using that to pay their employees. Let me tell you, I will tell you right now, we ain't getting paid. From experience, they're not paid. They're paying their board of directors though very well, and their stockholders also very well. But nonetheless, so we have to pass this now to correct this system. Everyone should have vision, dental, hearing, mental health, prescription drugs, physical therapy, whatever, you know, and that would be covered under the original Medicare. But since the plans are pinching off of that and their lobbyists are in the ears of our Congress telling them, well, look at what we can do. I mean, Medicare can't do this. Why? Well, you don't need that. So, you know, that's the reason why we have to pass this now before it's too late, because our seniors are seeing these plans. They get these really thick, nice packets. They go to their doctor's offices and there's brokers that set up these pretty tables that have all this free swag for these plans. And they are basically being coerced and convinced to go to that. Some of these plans offer transportation benefits. Nonetheless, a lot of this stuff that would be covered had it not been penny pinched away. And it's being penny pinched away because we're being told we can't afford it because they've given the corporate tax cut to the health plans. And that corporate tax cut should have been not cut and just used to fund our healthcare system. And so here we are, it's like one big circle of mess. So that's why we have to pass AB 1400 now, because these plans are going out of control with no regulation. They have a little regulation. They do have to follow Medicare CMS guidelines. But when you are the ones writing the guidelines, well, what rules are you really following, right? So anyway, I digress. I just wanted to add that in there. A lot of our people are choosing these plans, not because it's morally, ethically what's sound, it's because they can afford it. They need to get the most bang for their buck. These elderly, disabled people are living, you know, off of Social Security. Some people are making less than $1,000 a month and somehow surviving here in California. That is not a livable wage for California, but our seniors are literally only getting $1,000 a month and having to survive off of it. So paying a Medicare premium right now is just completely asinine for them. And so when they get a health plan that's less, you know, they're going to go for it. And so that's why we have to pass AB 1400 now, not only to provide them the care that they need, but before the health plans just sweep the rug onto us. And that's really where it's at stake. Dr. Bill and then Maureen. Oh, Barbara, did you want to add to that too? Oh, you're on mute.
I want to remind everybody, people are turning 65 at the rate of 10,000 a day for the next 10 years. And it's been going on already 10 years. Okay, so we can see the influx of people. And if they get steered over to the Medicare Advantage plans, it will completely decimate Medicare. Like you say, the whole program is just going to go up. It's just going to be privatized and we're going to lose all control over our health care. So that's another reason for now is the time. No more stalling. And by the way, Medicare in 1965 was brought in 6 months. Everybody in the country was enrolled across the board, 6 months and no computers.
Yeah, and I might add the Affordable Care that brought in 19 million people within 6, but actually I heard it was within 9, but 19 million people, no computers, you know, 3x5 cards and pencils. The Affordable Care Act cost the equivalent of 6 times what it cost to implement Medicare in 1965, the equivalent of 6 times, and only enrolled 11 million people.
Wow.
So it's, Barbara B, I wanted to ask you, because Gina also brought up this idea about premiums. We see one of the, and we know it's a trick, but perhaps you can explain it to us. I hope you can, of how it's a trick. We see some of these Medicare Advantage plans are charging $1 a month premium. That's it. And actually Aetna is coming up, I think it's Aetna, I have to check, but it's Aetna coming up with a zero premium. You don't have to pay for any premium. So how does that work when a person is drawn in because they pay? Because I did meet a man, I was doing canvassing for AB 1400, and I met a man who said, oh, mine is great. You know, it's just fantastic. I only pay $1 a month. And he said, but I'm going to have some surgery coming up and I'm not sure what I'm going to have to pay. So maybe you can enlighten us about that.
Yes. This is the big secret. And I always tell my high cap clients how each path of Medicare is funded. Fee for service, original Medicare, Medicare Advantage by capitation. You turn your Medicare over to a plan, they agree to take care of you. Medicare has to send them Here in California, between $800 and $1,100 a month. Every month, whether you use it or not, they get that money. So of course, why shouldn't they be able to afford zero premiums? None of them should be charging a premium with that kind of money coming in. They are so fat on money from the capitation. It's unbelievable. So, and now there's some plans that are going to a negative. They are going to pay or reimburse people for their Part B premium. Okay, because you need a Part A and Part B to get into the Advantage plans. They are going to refund that $148 for the person who signs up. Another, what I call enticer. Okay, they can't stop coming up with ideas to lure people in. And now we're going to give them 5 years of 60 to 64 people to do the same thing too? No, we're not. We're going to stop this right now.
So I just wanted to ask, I mean, you said that they're going to pay. I mean, even AB1400 can't compete with that. But here's the thing. When they control your network, going back to that, how to avoid necessary care, from experience, I will tell you, when you need that surgery, when you stress the system, which we know our elderly can with multiple comorbidities and chronic conditions, when you stress that system, when you're not just coming for your annual visit. Oh, and by the way, they will harass the hell out of you for your annual visit because their YAY scores and their RAF scores are based on the annual visit. So you will get harassed at least once a year, senior citizens, to come in for your annual because the whole Medicare payout is based on that. Anyway, when you stress the system is when you'll see the flaw. So just be careful. Don't fall for the glitter because it's not all the way gold. All right, I want to go to Dr. Bill and then we'll go to some in the chat.
Oh, thanks. So I was going to try and add on to what Maureen was saying about, you know, these people in power having whatever their highest tier, their platinum care, all that stuff. You know, people in privilege don't have a connection with those people who aren't in privilege. And so they really can't see what the needs of the rest of us are. So you're absolutely right as far as that's concerned. There's a concept, you know, that we should all be familiar with. Most of us here probably are, called the medical loss ratio. Everybody know what that is, right? Medical loss ratio, or what insurance companies consider to be a loss to them, is what they have to pay out for a claim that you have when you have to go to the hospital or see a doctor or whatever. When your insurance company pays that on your behalf, that's a loss to their personal profits. And I always call it, you know, instead of profitization, you know, or privatization, it's profitization, or as our friend Chuck Pinocchio in One Payer States Group calls it, profit first. Because if these companies don't make a profit, like, you know, a Medicare Advantage or these other ways, these the Republicans like to bring up, public-private partnerships, right? Public-private is just an opportunity for profit first, which is why, for example, we've done so poorly during the pandemic, because there was not enough profit in universal testing, contact tracing, you know, other types of COVID treatment, and especially non-COVID treatment that would keep people healthy enough to not get COVID at all, right? So there's not enough profit in that. So that money that, you know, is going in keeping insurance companies and big pharma, as we saw, profitable, is not going to provide these services, you know, mental health, long-term care, you know, care for alcohol and drug addiction problem. All those things that we know that we need, full dental care, you know. And there was a question in the chat about surgery, you know, that's not covered by MedicareForAll. This is where Gina likes to bring in the Brazilian lift. because
Unless
there-
medically necessary, like a bear swiped off your butt, then that could be. I
That's
mean,
right.
I can advocate. I could probably write the referral a little bit to say that that might be medically necessary, at least a skin graft.
but I think it was Randy Hicks who brought it up, and it's a great question, Randy. But we're talking about all essential medical services are covered. This is why California would catapult into that category of advanced countries that are, improving in our life expectancy, no longer falling off the curve like the rest of the country, and why, just like Barbara says, all of the other states will want to follow the lead of California at that point, because they will see how much better health outcomes are in California as a result. So Maureen's right, Barbara's right, and Gina's right, of course, and that's what we need to do. One more thing. President Biden himself uttered these words, not my words. President Joe Biden, not a big progressive, not a Bernie Sanders. He said, in referencing Big Pharma negotiating down drug prices, that they should no longer be able to price prescription drugs based on what the market would allow, that it should be based on what the needs of the people are. And that I credit to our movement, the whole movement that's bringing forward the injustice in Big Pharma doing that, and help insurance companies doing that in practicing these unscrupulous predatory pricing and really mafia business style practices that are controlling healthcare at this point. That's what AB 1400 undoes, that, as well as Medicare for All Federal. Okay.
Yeah, thank you, Dr. Bill. And with that, I do want to give a shout out to America's favorite grandpa and Senator Bernie Sanders, because, while people, I think this is a recent discussion that people were giving shouts out to Hillary for bringing up the 1993 Universal Health Care bill, which Bernie was right there on the stage with her, just putting that out there. He was right there. She didn't make it a household name. Medicare for All is a household name, and that is due to a lot of the activists right here on this call, you, me, everybody, where that was one of our key campaigns. We tried to put that crap in the platform. We did put it in the California state platform, and proudly voted against the 2020 DNC platform because they didn't want to put that in there. They wanted to word it, and we believe, but no, put Medicare for All. That's all you need to say. Very simply state it. There we go. But, nonetheless, I do want to give a shout out to Bernie, because this hard work, like I said, it would not have been a household name had he not brought that to the younger generation's attention. And this is the proof of we have the energy, we have the technology, we run social media. If you haven't noticed how many things have been canceled since we've gotten onto social media, and how many things have been uplifted, some not in a good way. But anyway, nonetheless, I just wanted to, give that little shout out there, and also, go back to, Medicare for All, or excuse me, Medicare AB 1400, and then the Medicare Advantage. Like I said, Medicare Advantage is a bamboozle. They will promise you a lot, and then when you squeeze it and when you start utilizing it, you will notice the problems. Trust me. I can tell you a lot of people got pissed off when I would say things like, well, you can't go there because it's not in network. I'm sorry, this hospital's not in our network, or this isn't in network. That's not in network. Oh, well, yeah, but we only do this type of dentistry, that blah, blah, blah. That's when people realize that they've been bamboozled. So don't let that happen to you or your loved one. Granted, I'm not unrealistic, and I understand those premiums, Medicare premiums, are going up again. And I understand that, like I said, people who live on $1,000 a month cannot afford that to have just straight regular A and B Medicare. So if you have to, then good. Choose a plan that meets your care, though, because know that when you use it, you will be restricted. All right. Going to Maureen, did you put stack again? Wait, stack.
Yes,
okay,
I did.
Okay, sorry.
Yeah, I just wanted to mention something because it is another thing that AB 1400 does. We did have kind of a guardian for costs rising in Medicare, and it was called the Independent Payment Advisory Board. There was always a Medicare Payment Advisory Board, but this was an improved one, actually, that was brought in with the Affordable Care Act. But in 2018, Congress repealed it and disappeared the Independent Payment Advisory Board. Now, this is another reason why whoever's in Congress has to have the same care that we do. Otherwise, there's a tendency to cut out the kind of agencies that would help all of us and help the budget and help keep things, you know, in the black instead of in the red. There was a health economist who was highly regarded. His name was Uwe Reinhardt, and he thought that this I'm going to call it the iPad. He thought it was very important because he said that given the dubious, this is his quote, the dubious style of campaign financing of which we are all victims now, that we need an independent Medicare commission as our only hope to restrain Medicare spending. And he further said the problem was we had to take the power away from Congress because they have very limited knowledge about the healthcare system, and also because they are beholden to special interests. Congress has pressured Medicare administrators to cover ineffective or needlessly costly methods of care, despite the fact that Medicare's founding legislation says that nothing in Medicare shall be construed to authorize any federal officer or employee to exercise any supervision or control over the practice of medicine. But we see that as exactly what has happened, is that we have Congress practicing medicine without a license. We have insurance industry executives practicing medicine without a license. So this is another reason we all need to be in, and the people in Congress have to be in our plan as well. Otherwise, they will, as one person said, they're not well enough informed to wisely use Medicare's buying power to reform healthcare, and they are enthralled to campaign contributors and producers and suppliers of medical services. And we're all, you know, very aware of that. Now, this board, the IPAB, this is the board that was called the Death Panel by Sarah Palin and Cornyn of Texas. So it has good credentials, good reasons for us to realize that this is what we need to reinstate. And AB 1400 has its version of the Independent Payment Advisory Board. And that's what we need to have, something removed from politics. Just like we have the trust fund will be removed from politics. It will be untouchable funds. So we do need to remove ourselves from political influence. And the only way really to do that is to include everyone.
Thank you, Maureen. Barbara, you had put something in the chat about Medigap being private insurance plans and have a premium. Was that directed towards someone who asked a question? Sorry, sometimes I get lost in the chat.
I think maybe it was a question that Dan, is it, who's the one that's doing Facebook Live?
Oh, Paul's dropping.
Paul. Maybe that was a question from Facebook Live.
Mm-hmm.
Well, anyhow, yes, the Medicaps are a private insurance policy for people. They don't have to have it, but many people in original Medicare do, because it picks up the 20% cost under Part B, or it might pick up deductibles, whatever. If they can afford it, you know, people, it's a sort of a means kind of thing. They will buy a separate insurance policy. And boy, let me tell you, see, Medicare is not free. There are costs incurred, and a lot of people take their chances and other people don't. But anyhow, all that would go away. We wouldn't have any more Medicaps. We wouldn't have deductibles, co-insurances, et cetera. We wouldn't have to worry about maximum out of pocket. All those business, I call them business kind of components would go away. We just have healthcare, period.
Barbara, can you review the problem with people who start out in a Medicare Advantage program and then decide they want to go to traditional, but they have a problem getting Medigap insurance? I mean, this seems truly outrageous. Maybe you can.
Oh,
address
yes,
that.
yes. Medicare is very good. It's a good time to set up a traditional Medicare when you first turn 65 or come out of employment and start Medicare. Because you can buy a Medigap and there's no questions about your health history. Okay, now we've all thought the pre-existing conditions went away, but it didn't for people 65 and over. Because if they wait a few years, try out a managed care plan, everything's going well, and then all of a sudden, boom, they have a serious health problem and they want to go back, guess what? They are subject to medical underwriting. They have to answer questions about their health history. The insurance company can deny them, charge them more, put a waiting period on them. So it's very difficult. There are a few times where they can, if they move out of the county, if their Advantage plan leaves their county, etc. There's a few things that give them a special enrollment period. And I've had to counsel people about how to do it that way. And people have moved their family member out of a county to another place so they could return them to a better healthcare situation with original Medicare.
I
Yeah,
also help guide with that, or unfortunately in my situation, it's not a pre-planned thing. So I'm having to battle this as the patient's in hospitalized, planning for discharge. And then usually what I have to end up doing is filing letters of agreement, letting this insurance. I mean, I've done this with Nevada. I've done this with certain plans that are just restricted to certain areas of California, and I've had to tell them like, look, once again, I can keep this person here in this hospital, thousands and thousands of dollars a day. Trust me, we are not cheap. Or I can get this person home with a little home health, but they're going home where they're safe. That's a big thing. You have to learn how to word these things with these insurance companies so where they can't argue with you. Number one, patient safety cannot be argued. So if I say I cannot send this elderly person back to their home in wherever, Merced or whatever, because they live alone and they cannot be alone, but they can stay with their daughter who lives in Culver City here in Los Angeles. But they need home health and I need you to approve that. Then I have to go do a letter of agreement with whatever home health agency. The home health agency is going to tell me, well, we need to connect with this person, that person. So once again, lots of time, administrative costs, people paying me to connect the dots here so that they can do a letter of agreement so I can get my patient to a safe place. Whereas once again, under AB1400 CalCare, poof gone, go home, bye. I set up home health for you. This is the agency, blah, blah, blah. Give me a call if they don't call you, bye. So once again, that saves so much of my time. Maureen, you brought up denials. I will tell you this past week, one of my colleagues was so frustrated. He was cussing at the phone because he has to set up a peer-to-peer MD to MD because the health plan was denying a patient who was currently in the ICU, saying that they don't see the reason why the person needs to be there. What? The doctor was so angry because he's like, what do you mean? And I've had to pull up the notes. I had to pull up the reviews because we send reviews to the health plan guys. So these health plans are reviewing the notes that we're constantly sending them. And I had to pull up those notes to see that what were they looking at that made them miss the fact that this person is critically ill and needs ICU level care. And I could not see what they missed. It was right there and they denied it. Once again, healthcare, Medicare Advantage, and having to do that, take that physician off the floor so he could go call that other physician at the health plan to cuss him out about why a person on an insulin drip with a potassium of 2.9, Dr. Bill, pretty obvious, right? That's pretty obvious. Any physician that sees a potassium at 2.9 and insulin drip knows that's ICU level, right? You would think But anyway, so I just want to say that's here we are back to the bloat and waste, why AB 1400. And this is what Medicare Advantage does. Now, if somebody wasn't diligent, if we would have never, if my colleague wasn't diligent on getting that, that physician to do that peer-to-peer, pulling these docs off the floor is like pulling teeth, I tell you, then that bill could have potentially, that denial would have been that bill passed to that person. ICU level care, that's not cheap. Could be 60 grand, you know, so that is why we do what we do, but Medicare Advantage at your finest, people. Sorry, Barbara.
Yeah, you know, there was one celebrated case. I know Barbara's going to answer a question also, but I just wanted to bring up, following yours, there was a situation where a patient had a cardiac arrest in his physician's office and became unconscious. And they called the ambulance to take him to the emergency care. And he was billed, the patient was billed the ambulance ride, even though he was supposed to have it covered. He was billed for the ambulance ride because he didn't contact the correct administrator to get permission for the ambulance ride. And they said they didn't accept the reason that he was unconscious and had just had a cardiac arrest. They did not accept that as a reason for him being unable to follow the protocols. So this is what we're dealing with. Barbara, we had a question for you.
Really quick, before I go to your question, Maureen, I just wanted to answer James. My eyes skipped over that. Can you sue AB 1400 board for denial of care even after appeals process? To be written, there's probably going to be a multi-level appeals process that will have to be written because Medicare has a multi-level appeals process. And once again, they're following Medicare kind of as a blueprint on this, but the board will write out an appeals process. It must have one. Could you sue if you didn't get? I think that would be a far reach, and good luck finding a lawyer that's going to take it. That would be a far reach if you want to sue. It's kind of like suing the federal government, but I wouldn't say it's impossible. Anyway, I'm sorry. Barbara, Maureen's question in the chat about, can you describe a hypothetical situation where someone feels they must leave Advantage and why that would happen and how traditional Medicare addresses the problem? Oh, Barbara, you're on mute.
I had a client a while back. Her mother was very ill with cancer, and she was in an Advantage plan, but she had found a better form of treatment in another facility. So we took advantage of the fact that if she moved her mother out of the county, she did, up to Sonoma, she would be able to return to traditional Medicare and buy a Medigap to help with out-of-pocket expenses. Okay. Now, one of the glitches when you suddenly do things like that is getting another Part D plan. I'm assuming that she'd be able to do that too, but that's another component because original Medicare involves Part A, Part B, a drug plan, and maybe the Medigap. All right. So she was doing it basically to get better care. She felt it was a better care at a different facility, different kind of cancer therapy or whatever. So that's where it would come into play. And does that answer your question, Maureen?
Yes, I was just curious as to what would prompt. I mean, we've read that when people become ill in a Medicare Advantage program, that is the time when many of them go back to traditional. So I was wondering what the typical case looked like of someone that said, I've got to get out of this Advantage and I need traditional. I mean, I'm wondering what in general is the situation for people that they would realize they need to make that change.
Yeah, it's usually a sense that they are going to get better treatment in a different facility. And
it's not a cost issue. It's not that they're suddenly slammed with a
No, so
No,
usually it's the
no.
opposite direction if it's a cost issue. When it's a
Right.
cost issue, they're going to Advantage from original,
Right.
versus vice versa.
Yeah, right. And anybody that's on this call, by the way, annual enrollment's coming up where
Yep.
people get to make changes, their drug plans, their Advantage plans, back and forth, whatever. So if you need help with this, please call your local in California HICAP. Okay, I'm a HICAP counselor. I volunteer to do this. And but they're in every county in California and practically every county across the country, where it's often called the SHIP program, State Health Insurance Program. So if you Google that, you can get to your county and then call the office and schedule an appointment.
And also, you know, for those of us who are younger, millennials, talking to you, help your parents and grandparents out, go online, help them compare. There's plenty of sites that will compare. Open enrollment is October 15th through December 7th. Oh my God, I know that by heart. Oof. That tells you something. But seriously, we do need to help our elderly out. Or if you have an elderly neighbor or someone like that, just ask them if you are in this fight with us for AB 1400, also be in the help in the fight and help protect them. AB 1400, I can't say it's going to be passed before December 7th, but you know, help make sure they get the care that they need. Maureen, going further into what you were asking, what I see in my work is that, yeah, it's the restrictive network of Advantage. So when they don't know how restrictive their network is. Sometimes these insurance brokers can go straight up and lie dead to their face. Yeah, you can go there. Sure, you can do this, blah, 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 blah. They just need that commission. And so when they do that, and then finally they need to utilize this and they find out that they can't, that's when they want to disenroll. So to disenroll from Advantage, you have to call the health plan and then tell them you want to disenroll. And then you have to wait usually to the 1st of the following month, depending on when you disenroll. If you disenroll, I think after the 20th of the month, then you have to wait to the 1st of that following month. So if you disenroll, let's say October 25th, you won't be fee for service until November 1st, or excuse me, December 1st, because you waited too late to disenroll. That happens a lot. And when I have to tell patients that, ooh, their families get pissed and angry at me. And I'm like, it's not me. I did not make the rules. I'm just quoting you CMS guidelines. And so that's what a lot of people do. So a lot of people jump over back to straight Medicare because they find out the network is too restrictive and they can't get the care that they need or where they want the care, or, you know, or they are leaving the state or this county that plan is, because certain health plans that are under Medicare Advantage, those medical groups only cover certain, like, you know, sections of California. And so, you know, they either disenroll solely from Advantage, they don't want the plan anymore, they just go straight to fee for service, A and B, or they disenroll from the medical group because you have the health plan. So let's say you go Medicare Advantage, Anthem, Blue Cross, and then Anthem Blue Cross, now you choose a medical group. So let's say you chose Anthem Blue Cross, you know, with blah, blah medical group, Joe Blow medical group, without implicating my formal job. And then that medical group is where that network comes from. So it's like a middleman on top of a middleman, if that makes sense. And I've gotten really used to being the middleman. So, you know, that's how I kind of know, but that's when they usually jump off. I
wanted to make a comment on that because several insurers, including Kaiser, Centene, and Molina right now, are being sued because they misrepresent their provider networks when they are selling their product to people.
I can see that.
Kaiser and Centene were about 35 and 37% of their providers that they claimed were in their network did not exist, were not in their network. And Molina was truly egregious with 85% of their providers that they said they had and services they didn't have. So this is a huge issue. And a related issue also is that the insurance companies, insurance corporations can end coverage for an entire system in a contract dispute. And that happened with UCLA several years ago, maybe a decade ago, I don't remember. And several 100,000 people lost their care until that dispute was resolved. And that meant people who were going to surgery didn't get their surgery. People who had cancer treatments had interrupted cancer treatments. So the insurance industry has people in a stranglehold. They have the systems like UCLA Health in a stranglehold. Right now, United Health is having a contract dispute with someone called Wellstar, and that's going to leave 80,000 people at risk of losing their care temporarily until that contract dispute is resolved.
Having been involved in those contract disputes, let me tell you, it's a pissing contest. And I think that the person, the individual patient, member, whatever they want to call them, stakeholder, sometimes when you get real corporate, everybody's a stakeholder, and they forget about them when they're at that negotiating table. And I've literally heard people say, well, I'm not budging. And I mean, they get excited. They're excited to know that they're getting ready to let this contract term out. Knowing that we haven't barely even notified the members of the health plan that this is going to that term out. You're just going to show up at the hospital, and now all of a sudden it's not contracted. And from my standpoint, this has gone on to where you show up at a hospital emergency, and then all of a sudden you think this is an in-network hospital. You actually did your due diligence of an in-network hospital, and then all of a sudden you're being told it's out of network, and we're shipping you to somewhere on the other side of the damn county. You know, how is that conducive to your care? How does that happen? Now, granted, I will say, if it is a life-threatening emergency, like you're having a major heart attack or something major that you have to be stabilized from, because EMTALA is a B word, Dr. Bill, EMTALA, we have to stabilize you. But at the same time, we still will move you depending on your plan. So if you're a commercial plan, like not Medicare, our rates are higher. So we have to move you out. We're not going to sit there and pay a higher rate. If you're Medicare senior, you may be able to stay. So that's what's going on the backside of this. Okay. And it's not pretty. And it has nothing to do with your continuity of care, has nothing to do with the fact that, the healing environment. Me having to put you in an ambulance and schlep you across LA County at 2 a.m. because I got a bed finally at a contracted hospital. Do you think that that's conducive to your care? Would you like that? No, your family wouldn't like that. But that is what's going on with, like what Maureen says, with these contract negotiations, and they do not care. They don't. That is not what is considered. All right, Paul, let's go to your hand.
Yes, I want to back up a little bit about upcoding. I recall watching a movie with Dr. Weisberg is his name, I believe, and he was describing upcoding and DEC, and what they would do if you had Medicare Advantage is the insurance companies would give you extra things like, hearing, dental, and all that. So you would do that, and then all of a sudden they boost your risk. The risk would go up, and then you'd end up paying a higher premium later. And I just wanted to know, isn't that fraud?
Is it? The question, you would think, but just like going back to that not providing necessary care because they can technically term a contract with the hospital that provides a certain cancer treatment to prevent people with that cancer enrolling in their group, that should be illegal. But that is not illegal because, well, you're not denying care if you don't have the contract with that facility, right? And so that's where they find, even though they're supposed to have all these protections against denial of care due to pre-existing conditions, these health plans have gotten even more savvy. That's why it goes back to saying those little masterminds that, can be pulled to the dark side, come to the light side of the force. So don't give them your genius ideas, give us your genius ideas so we can figure out what they're going to do and prevent us and stop it. But that's what they do. So I would say, yes, morally and ethically and everything in between, I would call that just terrible. But it somehow is legal because I don't have enough money to pull the ear of a lot of the politicians who allow this to go. Dr. Bill, you want to add to that?
I would, and thanks, Paul and Gina. That was a great explanation too. Upcoding for Medicare, upcoding for commercial insurance is bad. Upcoding is bad altogether. It's fraud, right? So fraud, insurance fraud, is a crime. But providers who upcode and anyone who has an incentive to upcode because of financial gains for the purpose. It's committing fraud, but they can be incentivized when the paying party has very deep pockets. And that is the government, that is us. It's we, the people, have the deepest pockets. So that's why these corporate robber barons are going after Medicare, especially to upcode and commit that fraud. That's why Rick Scott actually was prosecuted in Florida. You know, he got out of it because their criminal justice system in Florida is so corrupt. He got out of it and then got elected to be governor and then got elected to be U.S. senator, which is insane. You know, that's why it's Florida. But that's exactly what he and people like him do. They upcode, especially when it's us, when it's we, the people, who are covering those upcodes. I mean, it can be a very easy thing when the upcode is relatively subjective. Like, was that a primary, problem, an intermediate problem, a complex problem? That can be very subjective. Or there may be very detailed guidelines as to how to actually code it, and you have to follow the guidelines. The fact is that Medicare, and Medicaid are pretty good at looking at those codes, but these companies, the commercial interests, have perfected ways of getting around those guidelines, those coding guidelines, in order to effect their upcoding skills to the point where they can bilk you and me, who are paying the bills for these things. And they're incentivized even more when they have incredibly deep pockets, kind of like the military contractors. They're incentivized so much that they'll literally start wars in order to make their evil products. So in this case, they're incentivized by doing that profitization, that profit first mentality. And that is what upcoding is all about.
Thanks, Dr. Bill. Like I said, when you take the model and change the model of profit to care quality, the whole thing changes. And that's what's going on right now. We're changing the model. So when the model is not reporting back growth and revenue projections to the board of directors, but instead of answering to 40 million Californians, if you crash this system, you've got to answer to 40 million people. That really is an incentive to keep the system going. Versus saying, well, I just have to answer to 9 on the board of directors or 11 in the board of directors, and all they care about is revenue growth. So there's that. Okay, I just want to go back and, see if I missed anything in the chat. But yeah, I mean, this is a big fight, and it's going to be an ugly fight. The only reason why I think that we haven't really seen from the health insurance companies yet is because they don't think this is going to go. But let it go, let it hit the Senate. Like, that's when we really are going to have to fight, because right now they're not taking this seriously. Until it hits, like when it hits that Senate floor, I think and those of you who fought this on the Senate side, it's going to be a blood sport. For reals, because I don't think we've got some support in the Assembly, but crossing over to the Senate, there's some support there. We have some. Barbara, were you going to add something, or Dr. Bill?
Well, actually, it's always been the Assembly that stopped the bill. It's always been the problem in the Assembly. Whoops, am I still there?
No, you're here. We can hear you.
Okay, yeah. So now the fact that they're starting with the Assembly is actually probably better. I think that's, if we can pass the Assembly, that'll be pretty good, especially with who's the speaker there, Rendon? He's still there. What do you think, Maureen?
Well, I know Ash Kalra has been keeping Rendon. I think he's been really in good, close negotiations, that whole keep your friends close, enemies closer scenario. I'm not going to say they're enemies, but I have read The Art of War. And so, I think that he is in close talks with him, and he said that himself. So I don't, from a strategic standpoint, knowing Rendon's career, I don't think he will fall on the sword twice. He fell on it once and is still to this day getting heat for it. I don't think he's going to fall on the sword twice. So I kind of have put him down my list of people who will fall on the sword. But go ahead, Maureen.
Gina, I wanted to, because people on Facebook don't have the chat, I wanted to promote Dr. Ed Weisbart's 30-minute YouTube explaining upcoding. And that it's on our Healthcare for All website, Healthcare for All Los Angeles website. And it's also on our Facebook page, Healthcare for All Los Angeles. You can see the YouTube presentation by Dr. Ed Weisbart. It's very important because it explains the upcoding and also what's coming down the pike at us, the new horde of barbaric policies coming at us with direct contracting entities. That is also going to be dealt with one-payer states this coming Tuesday. If you go to the one-payer states website, you will see that Tuesday, and I'm trying to remember, I think it's 5 o'clock. They will be having a discussion with Dr. Steve Kemble about nationally this direct contracting entities, which is going to transform traditional Medicare into Medicare Advantage. It will completely decimate traditional Medicare, and it invite all the big players in the for-profit industry. And I want to remind people, in the insurance industry, we are not patients. We are not human beings. We are income generating units, IGU. That is what we're called. We are also called human capital. Human capital was a term used for slaves during the time of slavery. So those are our labels in the insurance industry.
Actually, certain insurance companies, that's the name of their human resources, is human capital. Just putting that out there. It really is. This is straight facts, but I really want to go back. I just saw something, Maureen, you asked me to explain balance billing, and I will to as much as I can, because I can't go too deep on the weeds on that one, but balance billing is basically like, okay, so you get a procedure done, and it costs, $500, right? Your insurance company pays $250. Well, guess who gets the balance? You. I'm paying back a $600 something balance right now. Payment plans, people, do not let them tell you that you can't do a payment plan, because I have, didn't hit my deductible. So my insurance only covered $147 of a $700 CAT scan. And so here we are, me, Gina, paying back $500 something. So balance billing, there you go. Like I said, can't go too deep. There is some rules about that they can't balance bill if they're like an in-network provider, but unless they can only do, if they're like an in-network, like tier 1, whatever provider, then they can only charge you your copay deductible or something like that. Like I said, there's a few in the weeds on that one. That's why I said I can't go too deep into that, because I'm not 100% familiar, because it is like Dr. Bill's spaghetti bowl right behind him. It is a spaghetti bowl. Balance billing is part of one of those lines in the spaghetti bowl. Dr. Bill, I see you have your hands up.
I just want to touch on 1 minute on the politics in Sacramento regarding AB 1400. And yeah, there is kind of a ping pong between the two houses, the Assembly and the Senate, and they kind of, vary depending. I mean, traditionally in politics, it's the body made up of a larger number of smaller districts that's more responsive to the people. At least it's supposed to be that way, right? Like the House of Representatives in Congress is the people's house, and the Senate is more like kind of the aristocratic, only 2 representatives per state kind of thing. So, but it's interesting, in California, at least, most single payer bills have come from the Senate side. And we've had very strong advocates, like people like Sheila Kuehl and Ricardo Lara, and even Kevin De Leon, who helped the last bill get through on the Senate side. And the bottleneck has been on the Assembly side, where Anthony Rendon, his pronunciation, not mine, has blocked it the last time, as you mentioned. But if you think of these so-called leaders in our, different houses in Sacramento as kind of the funnel point for influence, which includes both money and votes, right? So it's money and people. When the influence comes in as money, they're going to try to block these things, at odds with the people. When the influence comes in as people, we have the chance to overcome the influence of the money. And so if enough pressure is put on these leaders who are potentially the bottleneck in either house, then we can get past these bottlenecks. I think we put a whole lot of pressure on Anthony Rendon, and he's looking and sounding like he's giving way to that pressure at this point. I don't know if it's going to flip back to now have a problem with the Senate, but it is possible. But we need to apply that pressure, obviously to both sides and to the governor himself. So,
yeah, thank you. It once again, I think I've said this many times. This is a bottom-up bill. It's kind of like a pressure cooker, and we're the pressure, and we're cooking, and we're getting ready to start bubbling. And the more we get closer to January, the more the bubble. Like if you ever let a pressure cooker run amok or set the PSI too high, I have. You see that thing start getting ready to rock off the stove. I don't recommend that. Do not do that. That is not safe. But that's kind of what we are. We're the pressure cooker, and we're building our pressure. And which is why, another reason why, the author like Ash Kalra decided to go ahead and make this a 2-year bill, because the pressure and momentum we're building right now, we might not have been able to fully build that pressure right now. And so we have got enough pressure. And hopefully by December, our pressure cooker will be rocking on the stove, so that in January we will come full force and then send a large message to the Senate, like, oh crap, look what they did to the Assembly. Yeah, look what we did to the Assembly. We'll do it to the Senate too. So, we just need to get this through. And like I said, mainly to emphasize enough, we need to be able to explore. Right now, we have tons of reports. We have tons of studies. We have a commission that have now done all this research to say, okay, yes, this goes, no, this doesn't go, yes, it goes with this, no, it doesn't go with that. But nobody will ever be able to definitively say anything until we pass AB 1400, until the board can get to work. So at the bare minimum, I'm asking people to explore this. This bill is not anything truly definitive yet. And I just want to really put that plea out there that if you really want to shut us up and say that single payer healthcare does not work, then pass AB 1400 and prove it to me. If you really believe that all Californians deserve healthcare as a human right, pass AB 1400. So on both sides of this conversation, pass AB 1400. Either you're going to shut me up or you're going to make 40 million people happy. To me, that's a win-win. I mean, because I can talk a lot. All right, so we're coming in the last 7 minutes of this. And so I just want to share that on Mondays throughout this month of October, we are going to be text banking through CNA for AB 1400. So I hope that you guys will be able to join us tomorrow. Come back to our Facebook page. We will have the link and the sign up. We'll post that here in a second. I don't know, Paul, if you have the bit.ly that you could drop in the chat. Yay. Paul is on it. I have to give a shout out to Paul Newman. He has been here, and he is our back end. He's the one dropping links. Thank you, Paul, so much. He comes on 15 minutes early with me to get things ready. He launches our Facebook Live. So I just want to give a big shout out to Paul for making it happen. It takes a lot of weight off me so I can just sit here and run my mouth without having to drop links and make sure I'm letting people in the room and everything. So I just want to give a thank you. Thank you, Barbara, for coming and sharing your knowledge with us about Medicare. It's always good to have another Medicare mind, someone who knows those nitty gritties. I can provide my experience on the clinical side dealing with it, but someone who knows that back end more than I do is always appreciated, especially those guidelines. Lord help me with Medicare guidelines.
Gina, I'd like to ask Barbara if, Barbara, do you have a link for the CHIP counseling, or do people just Google it? Oh, you're muted. You're muted.
Yeah, hold on a second. I'll get it for you.
Thank you.
Thank you. That would be very helpful. And going back to, like I said, help, people who are younger, your parents, grandparents, those, if they're coming into that Medicare age this year, help them out, help them decide a plan that will work for them. Because like I said, there's a lot of ways to be bamboozled and choosing the wrong thing, and then you get stuck. So, feel free, to help them out, help them choose something, help ask them, what care do you get right now? What are you providing what are you getting right now? So that you choose, if they do go under Advantage, at least choose the best plan that will provide all the resources for you. If you decide to choose Advantage, if you decide to go for fee for service, well, you're okay. But there's still gaps there. So, you may have to look into a Medigap plan or something of that sort. All right.
I have a final comment.
Sure.
As a senior who's been on Medicare for 6 years.
What? You mean you're older than I am?
Oh, wait.
don't believe
I'm your grandma. Okay. So is Dr. Bill. I happen to know that. Only he wouldn't be a grandma, I don't think. Pa, I think. But anyway, I just want to remind all of you that are looking at Medicare who are younger than 65 and younger than 50 and younger than 45. If you are lucky, you too will be a senior, and you will be at the mercy of whatever program is or is not there for you. So this isn't just about taking care of grandma and people like me and Barbara and Dr. Bill, and I think Paul as well. But this is also about assuring that this is here for everyone when needed. We've all contributed to the Medicare system. Since 1965, people of this country have all been contributing into the system, and it needs to be there for everyone. I want it for my grandkids. I'm not working on this for me really, because I'm okay, I'll get by and I don't have that much longer anyway, right? A couple of decades maybe. But I look at my grandkids, 10, 8, and 3, and I want it to be there for them. And I want it to be there for Gina and for Erica and for everyone else. You will be surprised how fast life goes. And once you're a senior, you are much more vulnerable than you ever were, no matter how well you take care of yourself. There are, things that are unexpected, and we all need help. And you know the value of a civilization by how well it cares for its elderly and its young, because those are the two times in life when we really need other people to be there for us and help us and care for us. So we want this for everyone, and we want it for all of you who aren't there yet. But if you're lucky, someday you too will be a senior.
Exactly. And do you really want to be left and vulnerable to the TikTok generation? No, I'm kidding. No, shout out to Gen Z. You guys are awesome TikTokers. I haven't mastered TikTok, so I'm kind of hating. I need to get on TikTok. But it is very important. So I want to close this out by first asking, if you enjoy our CalCare office hours, please join us at HealthCareForAll Los Angeles. And if you just want to throw us a little money, because this is a labor of true love, we don't get paid for this, feel free to donate. And Paul will drop those links for you in our chat and on Facebook Live. We would love to have you as part of our organization. We are volunteer led and volunteer ran. And anybody who has been an activist volunteer knows how exhausting it is. So the more energy we have, the sooner and the faster, and the overall is great. Just overall great having more people here. As you see, we always have fun, and you're always welcome to join us. If you believe in the single payer fight, we encourage you to join us here at HealthCareForAll Los Angeles. And if you're a physician, please feel free to join at PNHP too. Dr. Bill can give you all the info about that if you're a physician interested in getting more involved with PNHP. Also, lastly, I want to end with, we are going to be moving office hours coming into, the fall holiday season. We're going to be doing office hours every 2 weeks. So we'll be back on October 17th. And then coming back into January, when this bill gets reintroduced, we're going to be back probably weekly. And if it really gets heated, we might even come back more than once a week as we follow this bill through the legislature again in January. But for now, we will see you guys all again on October 17th. Healthcare for All Los Angeles is going to continue weekly text banking. And we're going to be also helping promote other events going on with CNA to help promote the, AB 1400 and everything else going on. So I will once again bid you guys a very happy Sunday. I hope you guys have a wonderful week, and I look forward to seeing you guys again soon. Join us tomorrow for text banking. Bye, everyone.
Bye-bye. Thank
Bye.
you.
Thank you.
Thank you, everyone. Thank you, Barbara, Dr. Bill, Paul, Gina, Jeffrey,
Erica.
everyone who was on the call.
Thank
Thank
you
you,
all.
guys.
Have a nice evening.
Appreciate
Take
it.
care, everyone.
Take care.
care.
Thank you, Gina. You do a fantastic job. I'm waiting for your comedy show. Just kidding. You and
It might-
Dr. Bill, would be the pair.
It could be
Okay.
a fundraiser. I don't know.
Yeah,
You guys would be great.
Thank you, Gina. You did a great job.
Oh,
Thank
thank
you.
you. Thank you. All right, you guys. Have a
Thank you,
great
Bye.
night.
Barbara, for coming on again.
Okay,
Thank
bye-bye.